The session now.
Yeah, so good morning. So as I mentioned, we saying like we have a 4 minute for each speaker, and after two discussions, two presentations, we have rebuttal for 1 minute for our first speaker, and then you have a discussion. Muna will be discussing medical cases, and then by the time Mahesh will be back, he'll be discussing for posterior segments or surgical cases. So let us start with, again, I'm passing on to Nitin now. So, Nitin, please take over.
Yeah, thanks, Pramod. Without wasting much time, we'll start on the first topic regarding management of CNVM in AMDs, whether we can manage only with Octa or whether we need FFA and ICG. We are speaking for Octa will be Dr. Unni Krishnan Nair. Dr. Unni, you can start now.
Thank you, sir. Hi, Unni. Yes. I have got a small issue with my screen here.
Dr. Giridhar can keep your talk ready. On
You
FFA.
can go to the home, I think. It is not in the home, it's in animations.
No, it is. I cannot see my screen. It's kind of.
Okay, we are seeing.
We can see you. Yeah,
we can see
your screen.
We can see
You can see your screen.
We can hear you also. Yeah, let me see if I can start slideshow. Yeah.
सर नीचे कॉर्नर में आइए नीचे last.
Let's see.
Yes, yeah, it's okay.
Okay, sorry for that delay. So I will be talking about whether OCT is adequate. And for the fun part of it, let me say all debates are about semantics. The term adequate, essential, and AMD are key to success in this debate for me, I believe. So, but we will not use the lamest excuse, that is that we're using anti-VEGF, therefore we do not need to do imaging properly. So in AMD, I would like to go beyond the point that it is not just about diagnostics. So we are talking about treatment decisions, responses, prognostication, and modulation. And that is where I feel that OCTA passes where conventional may not be that adequate. So the conditions where a wonderful advantage is derived is CNVMs in the presence of atrophy, response to treatment, and non-exudative CNVMs in AMD. So I'd like to show you this picture. I'm sorry, but I cannot see the pictures very clearly. You see a membrane over here and the corresponding picture. But instead of the FA, what is wonderfully brought out is the exact vasculature of the membrane, which is brought out in OCTA, as you can see in the image over there. So I think all the images are getting overlapped on my computer. So I simply cannot proceed. I'm sorry about that. I think you can see it, isn't it?
We can see it. We can see it.
Yeah, so I don't know what I'm showing on my system.
It's a multicolor image only.
Yeah, I know. I mean, all the images are getting.
Would you like to speak after Dr. Giridhar?
Yeah, I'll do that. I'll try to sort it out.
We can do that. Yeah.
I'll try to sort it. I'll try to get on another computer.
You can stop the screen sharing.
If I can find it. Yeah. Okay.
Dr. Giridhar, can you take over? Dr. Giridhar? Thank you. You have to unmute yourself, sir.
Yeah, we'll have a 4 minutes here in timer.
You have to unmute yourself, Dr. Giridhar.
Yeah. Can you hear me?
Yes,
sir.
Yeah, actually it got unmuted automatically. So Anyway, this is the first talk in this debate, and unfortunately, the very fact Unni is finding it difficult to present, that itself shows, I think he is totally getting confused. Anyway, I am talking to say that FFA and ICG is essential, basically because, these are the reasons. It clearly defines patterns, it's real-time and dynamic, it's possible to correlate with OCT, it can detect low-flow lesions, and Unni said about treatment. But treatment, what to give? Not everything is anti-VEGF. Some of them need laser, some of them need PDT. Can we decide that based on Octa alone? Very difficult. And how are we defined? Definition of disease even today is based on dye-tested techniques. You see the polypoidal vasculopathy, you see RAP lesions. All these lesions are now diagnostically even now defined based on dye-based imaging and clearly defined patterns. Our textbooks talk about classic and occult CNVM based on fundus fluorescein angiography. And the real-time imaging and video imaging demonstrates very clearly, beautifully, the vascular anastomosis or pulsatile polyps, which is very important to detect because that can lead to a large hemorrhage if you are very aggressive in treatment. And finally, the ability to correlate with OCT. And I would like to ask, even today, the diagnostic criteria of specific lesions as far as wet AMD is concerned is based on angiogram and OCT. You can see here the beautiful hyperfluorescence right in the center of the PED in a case of a RAP, and when you do the OCT there, you can see this split in the retinal pigment epithelium through which the neovascular network is growing, and also the classic CNVM. Ability to detect low flow lesions. This again is very, very important. You can see this polypoidal lesion beautifully demonstrated in an ICGA, but fails to be seen in an Octa network. And this is not what I'm defining. This is what the textbook says, that fluorescein angiography has better sensitivity when detecting vascular lesions with low flow characteristics. Octa operates by capturing 2 consecutive B scans at clamping location to detect red blood cell information. And therefore, it is possible that low turbulent flow can miss some of these lesions, especially polypoidal lesions. Myopic CNVM, they say Octa is very useful, but suspicious CNVM like this is missed in Octa. But at least you see a suspicious leakage in fundus fluorescein angiogram. And basically for PDT-based treatment, you need to really define the complete network, which is beautifully seen in an ICG angiogram. In an Octa, you may see a network, but the exact extent of the network and the polypoidal network, the presence of the multiple polyps is beautifully delineated only with a dye-based angiogram. Field of view is definitely a great issue with Octa. Conventional Octa has got very little field of view, but if you go for a larger field of view with Octa, you need to spend a few crores of rupees to get a machine. But as far as the peripheral lesions are concerned, they are beautifully diagnosed with bidiagonal imaging systems. Octa has problems to deal with, like, especially the artifacts, the fixation, and the exorbitant cost. All these things act as an impediment for persons to use Octa. The very process of acquiring images in Octa, in the intricate process, especially to understand the red blood flow, can lead to a large number of artifacts. Large PEDs can cause anatomical distortion, and here you can see the PCV network, which cannot be detected in Octa because of the large pigment epithelial detachment. The same applies to a presence of a large amount of fluid. Again, you cannot really interpret in an Octa, but you can see in a dye-based angiogram. Similarly, this also has been purely defined in textbooks that the sensitivity of Octa to identify CNV in vascular detachment or polypoid is lower than that in other types of CNVM. Fixation, poor patient fixation can deal with very difficult situation as far as Octa acquisition is concerned. And apart from that, we have the projection artifacts, we have motion artifacts, either related to the patient or the examiner. We have segmentation errors. And finally, what is the access to Octa? This is the most recent ASRS PAT survey, which shows even in the most developed country like the United States, only 30% of people have got access to Octa, and only 10% of them are really interested in buying a machine. And what does the VRSI survey say? It's a good research tool, with limited clinical application. And if I tell my patient that I'm going to treat you with a research tool, it will be a really difficult situation. Patient will wonder whether I'm being made a guinea pig. And therefore, my dear friends, dye-based angiography is old, but it is still gold. So don't please go and invest in a large machine like Octa at this moment when you're finding it difficult to pay even the existing EMIs in this pandemic. Thank you.
Thank you, Dr. Giridhar. That was a great presentation. Unni, are you ready? Dr. Unni?
I'm here, sir. I'm ready.
Yeah,
Okay, go ahead.
you can start. Yeah.
Okay, yeah. So I will just skip to a few things and yeah. Yeah, so I unfortunately just heard sir's last two comments saying that it's a research tool and you shouldn't spend money on EM.
Share your screen. Yeah.
Please share your screen.
Can you see the screen?
No.
No.
रणवीर जी प्लीज हेल्प कर दोगे स्क्रीन शेयर करने में?
Yeah, I've got it.
Picture screen.
Yeah, is it sharing now? Yeah.
It's coming, but it's
Yes, yes.
still not
Picture is
appeared.
Yeah,
It's open.
picture is not.
Yeah, it's
Yeah.
open now. You go to the full screen.
Yeah.
Yeah.
Is it okay?
Yeah.
Yes.
I'm sorry for being such a nuisance, but anyway, let me continue. So anyway, this is what I wanted to show the pictures. That it's not a research tool, and eventually we have to integrate research into our clinical practice. So this is a picture of a CNVM here, but this is what you see. You see the perfect vascularity of that membrane. Why do you need to see it? Yes, because it guides your treatment and you can assess regression also. Here you have a multicolor picture showing the green shows fluid, the red and the dark area shows hemorrhage, and this is how the hemorrhage looks on on an autofluorescence and infrared. But and this is what the whole picture looks on an OCT. But the definition that you get, the membrane definition that you get, this unparalleled. You do not get this kind of image on conventional angiography, how big it is, which is a central stem, where is the feeding vessel, how large it is. And all this becomes of relevance when you start treatment and when you watch it regress and go. So this is a blow up of that image also. So again, here, the fluorescence has totally masked the whole image. You do not see any definition over there. Is it good enough to tell you there's a CNVM? Yes, but we are supposed to proceed beyond that level and go beyond it. So this is the area by which you mark, and supposedly a PDT marking how large is your spot size, but this is the exact extent of the image. You can see that there are projections of the vascular net in different sides and different areas, and this is the exact shape where you see anastomosis going around, which is a poor prognostic feature. Non-exudative CNVMs, you see a flat thing. There is no SRF, no features, but when you do an Octa, you actually see a vascular net over there, which shows it's a non-exudative CNVM with a destiny to become an active CNVM in about 2 years, 22% destiny. So here again, you see a raised lesion. There's nothing, there's no fluid over there, but underneath the lesion, you see a vascular network. So is it a research tool? Yes, it is a research tool that is going to give you a couple of years in advance before you start, a warning before you start worrying about the patient. So this is that non-exudative membrane again. Another non-exudative membrane, a flat retina, but a large quiescent CNVM growing under the retina, which is destined to become an active CNVM with hemorrhage and edema later. So in the presence of RP atrophy, this is a patient with RP atrophy, you know there is some sort of activity, but there is a total masking. You don't see any activity because of the RP changes. The angiography is simply not good enough to tell you what is happening underneath, but the OCTA shows a wonderful vascular net highlighted at this particular position. So these are advantages that are really derived from the OCT angiography. Response to treatment. Here you see a picture of a large filamentous area with anastomotic channels. After treatment, you see that the small anastomotic channels have disappeared and only the large filamentous areas are remaining. And then after some time, you see regrowth. This is what you mean by regrowth. Before the patient becomes has additional fluid, you see that the CNVM is growing back again. These features you cannot simply see in an angiography, a dye-based angiography. Based on the patterns, you have a lacy pattern, a C-fan pattern, a filamentous pattern, and ill-defined or fishnet patterns. And these are the different kinds, the lacy pattern, the medusa head, the C-fan head. But what is interesting is there's a new pattern described called the fishnet pattern, a tightly dense pattern. And why is it important? Treatment response, there is a very poor response to the fishnet pattern on anti-VEGF. So again, good anatomical response is when the filamentous things go good. Poor anatomical response is when the whole network does not go away. And as you see, this is one of our studies where we looked at the fishnet patterns, and after anti-VEGF, it increased in size. So the relevance in treatment response is the ability to do an OCT angiography as often as you want to. Look for anastomotic channels, and you can base your treat and extend just on an OCTA just before your treat and extend policy, and you can see which all patients escape from the treat extend also. This is my last slide I want to show you. This is a picture of an angiography you've done, but then you do an OCT angiography and you see a small membrane hiding in the behind. This is a case of I found it while I just missed it in the previous case. So the advantage is that in diagnosis, it becomes clarity to certain situations, but in treatment response, assessing the type of vascular network and recurrence base of reappearance of vascularity. What I would like to say, and like to say very clearly, it may be a research tool you may consider, but we are going this way. My talk is proof enough, I believe, to say that this is the next big thing that we should invest in to give better care for our patients, no financial considerations. Thank you very much.
Yeah, thank you, Dr. Unni, and Dr. Giridhar. I'll hand over to Dr. Mona to decide the winner if there's one in the first debate.
Thank you, Nitin.
Unni is the winner. I don't want to go into, I am 20 years elder to it. So
and Dr. Giridhar is very gracious in that.
Old is gold.
Now you two will meet Muna outside and come back. Both meet Muna outside the hall and come back. She will announce the winner.
Now, I don't know whether I fall into the old category. Yes.
You are neither old nor young. You are in the middle.
Unni and Dr. Giridhar, let me say, are experts in the field. And we have heard from people who probably have the most experience in both the investigations. And what we saw from both of them is the fact that these investigations have a role at different points in time. The advantage of fluorescein angiogram and ICG is something we have learned over the years. We know we can identify leakage. We understand the patterns. Everybody understands the patterns. But we also know there are cost constraints. You cannot repeat the test every week or every month like we would do an Octa. And then because there's a lot of fluid, sometimes we may even miss the lesions. But definitely fluorescein angiogram and ICG, there are selected roles like low flow lesions like Sir mentioned. And as far as Unni's talk is concerned, Octa is a wonderful research tool. Like everyone, before we gave the vaccine, we wanted proof that the vaccine works. We wanted research studies before we accepted it. So research is essential, and I think we've learned that research has proved that Octa is invaluable. It has its problems. If all of you noticed in both the talks, they both relied a little bit on OCT as well. So I think the winner of the talk is both the debates is actually OCT, which seems to be common on which is
what I was thinking that, it should be OCT versus something actually, because now I think everyone is treating based on OCT.
But still, I would say Octa has a role in diagnosis, assessing treatment response, the ability to frequently do the test as often as you want without the patient definitely has a role. But I would say it's evenly, and OCT probably is the winner of this.
Thanks, Mona. You have won the diplomacy war. So we go on to the next topic on anti-VEGF monotherapy in PDR, a hot controversial topic, and we'll be speaking for is Dr. Vinod Kumar, and against this is Dr. Neeraj Sanduja. Dr. Vinod?
Yeah, good morning, everyone. Should I share my screen?
Please.
Yeah, I hope my screen is visible and I am audible.
Yes, sir.
So first of all, I like to thank Dr. Pramod Bhende sir for including me in this interesting debate session, and also for trusting me to defend this difficult topic in today's scenario. So I'll present my view here. So we know that VEGF remains the most important factor in the pathogenesis of PDR, and most of the factors which have been described ultimately work through anti-VEGF. So it makes sense to target anti-VEGF, the VEGF. Now all have been talking about DRCR protocol S, and I'll just comment on it in a single slide. It was basically an inferiority study, and what we found actually that it had certain advantages over pan-retinal photocoagulation, the monotherapy with ranibizumab, in terms of lesser rates of DME development, lesser rate of vitrectomy, and better improvement in the visual acuity. Now, the same thing was shown by Clarity study, where aflibercept was superior to the standard pan-retinal photocoagulation in terms of regression of neovascularization, in terms of resolution of vitreous hemorrhage, in terms of needs for vitrectomy, and in terms of development of macular edema. But were these studies conducted out of blue? No. So there was ample data even before these studies in terms of RIDE and RISE trials, VIVID and VISTA trials, and Panorama trials, that most of the patients who received anti-VEGF therapy had at least 2 steps of regression in diabetic retinopathy severity scale when followed up over a period of 1 to 2 years. Now, we all are familiar with side effects of pan-retinal photocoagulation, and we have all seen this kind of picture where the patient has undergone photocoagulation extensively, but the neovascularization just refuses to go away. This is associated with loss of peripheral field, night vision problems, and frequently it is associated with macular edema, increase in macular edema, which again would require anti-VEGF injections. And we all know that in 5 to 10% of the cases, there is progression of disease in spite of this is the recent study which has shown pictures like this, and where there has been people have been ultra responders. The retinopathy has virtually disappeared with 4-step improvement in up to 1/3 of the patients, and they have been now termed as ultra responders. Now, some may argue that anti-VEGF injections require repeat injections and follow-up. But remember, we regularly use monthly injections in AMD. And for DME, we started with all the studies started with 1 injection, but now we regularly use monthly injection when we found that, and actually anti-VEGF monthly injections were better than the macular photocoagulation. In fact, one of the courts in retina today, back in 2006, one of the surgeons commented that in my experience, anti-VEGFs really work well, and after a few years, will not have to laser macula. I think that is very much a reality now, and few years down from now, we won't have to laser even for PRP. And tell me a single chronic disease which does not require a regular follow-up. In fact, several long-acting anti-VEGF options are in pipeline, and I see from now, 5 years from now on, we will not be lasering and destroying the retina. Anti-VEGF injections are costly, but we have all seen the cost of the anti-VEGF injections have come down quite significantly. We can use bevacizumab, several generic bevacizumab injections for eye use are in pipeline. But then quality comes at a price. We all have seen that phaco gives much better results, but is more expensive. But we don't go after the price, we go after the quality and the outcomes. And as the technology advances, anti-VEGFs and the long-acting anti-VEGFs are going to become cheaper. The risk of endophthalmitis, we have seen that it is quite significantly low, and patient selection is paramount, as in all treatment decisions in medicine. To conclude, anti-VEGFs cause fast and effective regression of neovascularization. Anti-VEGF downgrades the diabetic retinopathy and avoid the side effects of the laser and prevents the destruction of retina. Thank you very much. Thank you.
Thank you very much, Dr. Vinod Kumar, and thanks for joining us. And it's an excellent presentation. maybe it's turn from Neeraj to defend his topic. Neeraj, please go ahead.
Good morning, PV sir. Thanks for this opportunity, and my other teacher, Dr. NSS, and Mona. Good morning, and everyone, all friends. So I'll be defending my talk. It's visible, sir?
Yes, yes.
Yeah. So this is anti-VEGF monotherapy in PDR. As Dr. Vinod said, like PDR progression can be stopped by doing anti-VEGF. Earlier studies, Rise and Ride study showed that despite giving 24 injections, 10% of the patients went on to develop PDR. In protocol also, almost 20% patients went on to develop PDR despite giving repeated intravitreal injection of anti-VEGF. And as far as the panretinal photocoagulation has been concerned, even data from ETDRS has shown over a follow of 16 years, 42% patient maintained vision of 20/20 or better, or 84% had 20/40 or better, showing clear-cut role of laser photocoagulation in PDR. And this was an interesting protocol S, which was done for 2 years and extended to 5 years. In this, only 67% of the patient, they had a follow-up of 5 years. And visual acuity in eyes which received monotherapy or the patient who received laser photocoagulation, the treatment effect was same. Even it was said this anti-VEGF treatment is non-inferior, means it is not superior. And if you look at the results in protocol S, 2-year results are comparable, DME status was improved, and there was a better preservation of visual field. But if you look at 5 years as shown by protocol S, the visual field loss was comparable in both the groups, which was a major outcome of this study. But looking at the potential short-term benefits of anti-VEGF, you are going ahead with a significant cost and treatment burden on the patient. Another study by Boyder and Todani associate showed that area of capillary non-perfusion remained same, rather worsened, despite giving anti-VEGF injections. So basically, the whatever improvement you are seeing clinically, it is a sham. It may lead to complacency and maybe lack of close follow-ups, leading to more worsening of diabetic retinopathy in such patients. And also, it has been seen that once you stop anti-VEGF medications, approximately 30% of the patient, the retinopathy again will worsen. And whatever comes back, it comes as a bounce, and the progression of diabetic retinopathy is much worse if you treat with laser photocoagulation. Another side effects of anti-VEGF are intraocular pressure rise, endophthalmitis in few cases, and even the risk of TRD, which you may not be able to see sometimes, and it can lead to retinal detachment. And also treatment interruption can lead to significantly greater number of eyes with TRD and neovascular glaucoma progression as a rebound phenomenon. And PRP laser has a good regression of the disease as shown by ETDRS and other protocols also, and stability over a longer period of time. So if you look at Indian scenario, you are putting the patient to expensive therapy where most of the patients, they are not covered by healthcare support from the state level, and they are depending on their financial health only. And also follow-up compliance is as such poor in Indian scenario, and need for monthly injection, and then keeping a record when to visit a doctor is quite challenging. And whereas you are able to do laser comfortably in 2-3 settings and making the patient safe. And even the phobia of multiple injection is always there. Patient starts to run away, and risk of endophthalmitis. And another thing, this is still progressing despite such expensive treatment. So your compliance is poor, expensive therapy with no health cover, additional risk of injection, phobia of receiving injection. So all this, I think it doesn't warrant giving anti-VEGF injection in such scenario. And PRP is a gold standard, and it is cost effective, completed in a few office visits, and the long lasting effects. Yes, anti-VEGF can be reserved in few cases where you are planning to do laser, not able to do laser because of vitreous hemorrhage. You can want to wait for the vitreous hemorrhage to clear. So this can be but it cannot be a monotherapy. So a big no for anti-VEGF monotherapy in PDR cases. Thank you very much.
Yeah, again, you're going as if old is good. Neeraj, no, excellent presentation. Over to Mona.
Can you stop screen sharing, Dr. Neeraj?
Yes, sir.
Yeah, are you giving 1 minute time for Vinod to rebuttal?
Vinod, you want to say something?
For 1 minute, you have Vinod.
Ma'am, as I told, no, it's very difficult topic to defend as of now. But I think we go back 1 decade and we all used to laser, and I think hardly we do macular laser nowadays for diabetic macular edema. So the same thing is going to happen. The only thing what is probably going to change is we are going to treat these patients earlier in their treatment, probably at this stage of NPDR or severe NPDR or very severe NPDR.
Okay. So thank you, Neeraj and Vinod, for debating on this topic that I'm sure we'll hear more of in the next few years. I think all of us were skeptical when we heard of anti-VEGF monotherapy for PDR in the past. And now with the results coming out, we are learning that maybe there is a small role somewhere. If we look at the initial data of 2 years, everything was very nice. When we look at protocol S 5-year data, we see what Neeraj mentioned, the dropout. The question, the significance of the dropout is because this is proliferative diabetic retinopathy and not macular edema, because macular edema rarely blinds people, whereas untreated PDR can blind people. So I think that is the one difference between the two and the importance of the follow-up. But if we dissect out the protocol S data, we realize that patients with moderate PDR did good at the end. Patients with very high risk PDR did not do as well. Patients with associated macular edema did better. And the study Neeraj showed us, which probably is a little bit of real world that we see, is that loss of follow-up is a big issue with high risk PDR. So to conclude, I would say both have their roles. Definitely, if you see a patient with moderate PDR and macular edema that requires treatment, there's still a role for anti-VEGF therapy. But we know there is the crunch effect when there is fibrosis, when there are mature vessels. We know anti-VEGF will not cause regression, may worsen the traction. So I would say still each has its role. And in our Indian scenario, I would say more than 50%, we would still want to think of PDR with a few selected cases where rather than laser, we would give anti-VEGF. So well done, both of you.
Thank you, ma'am.
Thank you, Dr. Mona. The next topic for debate will be DME and cataract surgery with intravitreal anti-VEGF injection. Should we do it at the same sitting or should we do it at separate sittings? For same sitting will be Dr. Dhanashree Ratra will be speaking, and for separate sitting will be Dr. Ajit Babu. Dr. Dhanashree? You're muted, Dr. Dhanashree.
Can you hear me?
Yes. You have to share your screen.
Yes. I am trying to share my screen. Yes. Is it okay, visible?
Yeah. Yes.
Okay. So I'm going to talk about same-sitting cataract surgery and anti-VEGF for DME. So no financial disclosure. So if you have a patient who comes to you with a 65-year-old patient with moderate amount of cataract and a center involving diabetic macular edema, where the vision has reduced to 3/60, not improving further with glasses, the OCT is showing you macular edema of 650 microns. What is your line of management? For me, it's a no-brainer. I would do a combined cataract surgery with anti-VEGF injection, provided there are no contraindications. There are obvious advantages. It is like shooting multiple arrows like the Bahubali. So you are taking care of both the conditions at the same time. It is convenient for the patient to finish both in one visit and you avoid multiple visits. It takes care of both the problems and thus maximizes the visual recovery. However, my opinion may not be important to you, but this is the era of evidence-based medicine, and let us look at what is the evidence in the literature. Now, we know that cataract occurs more frequently in diabetics and at an earlier age. We know that the outcomes of cataract surgery are in diabetic retinopathy patients are worse as compared to other patients. And we know that the patients with coexisting diabetic macular edema, hardly about 53% of patients will achieve a visual acuity of 6/12 or better after cataract surgery. We also know that DME occurs because of blood retinal breakdown. We know that the cataract surgery induces hypoxia, inflammation, and which further leads to aggravation of the blood retinal barrier breakdown and progression of DME. Now, if you look at this article, they have measured the the VEGF levels after cataract surgery, and they found that the maximum concentration of VEGF was seen 1 day after the cataract surgery. So obviously, it makes sense to give anti-VEGF immediately at the end of the surgery at the same sitting, because that is the time when the inflammation is highest and the inflammatory mediators are released. So this is another study, a prospective randomized study, which is the highest level of evidence that we have. And in this study, eyes were randomized to phaco alone or phaco with Avastin injection with a 6-month follow-up. And they found that the progression of diabetic retinopathy was more common in patients who did not receive the anti-VEGF as compared to the patients who received anti-VEGF. The progression of diabetic macular edema was also much higher. Nearly 50% of patients with the phaco alone group progressed as compared to only about 5% in the patients who received the anti-VEGF at the same sitting. So this is another study. It's a real world evidence where you saw that patients who received the anti-VEGF at the sitting at the same time as cataract surgery, they maintained the BCVA at first and third month, and as well as the CFT was less both at first and third month. This is another randomized prospective study which had again 2 groups, a sham group with cataract surgery alone and another with intraoperative ranibizumab injection. And here they saw that patients who had only cataract surgery had higher thickness of macular edema, the higher macular volume at 1 month, and with poor best corrected visual acuity. And they concluded that at 6-month follow-up, patients who had ranibizumab injection had better visual acuity than the sham injection group. Another prospective randomized study had 3 groups. Patients who received injection at the time of operation, patients who received injection 2 weeks pre-operatively, and 2 weeks after the surgery. And they concluded that the intraoperative injection of ranibizumab was found to be more effective than either a pre or post-operative injection of anti-VEGF. So you can see that the evidence so far favors same-sitting cataract surgery with anti-VEGF. It is obviously easy to administer. It is also safe with all the surgery that we have now, and it is comparatively cheaper rather than doing it on 2 separate sittings. So with this, I rest my case. Thank you.
Thank you very much, Dr. Dhanashree. Nice presentation. And we have Dr. Ajit Babu putting his side now. Yes.
Okay, thank you, Dhanashree. I think you are a VR surgeon and you will be in favor of us. Your first slide, you said it is a blinder. If you see the fundus photograph, by itself speaks that you cannot see such a clear fundus with macular edema. So with such a kind of a cataract, you cannot assess what is the type of macular edema you are dealing with in diabetics. So degree of cataract is very, very essential. And these days, majority of the cataracts are 6-9 cataracts or even 6-6. I wonder why they do the cataract surgery at the first place. Such a case, you can easily assess what the type of diabetic macular edema you are going to deal with. And if you such a media clarity, if you are not handling the diabetic macular edema, probably what you said can happen, that after cataract surgery, there can be a worsening of diabetic macular edema. That is my first point. Second point, in which cases you are going to give the anti-VEGF injections. If you see non-center involving macular edema, still I practice a focal or grid laser in areas of leakage rather than anti-VEGF injections, because single sitting laser will resolve for longer time. You also clearly know that vitreomacular traction is not a case for anti-VEGF injections. In addition, ischemic maculopathy, you should not deal with it. Whereas only focal or diffuse leakage, you go for anti-VEGF injections. And if you see the pre-existing diabetic macular edema shall be treated before cataract surgery rather than simultaneous. You dry the macula, go for cataract rather than leaving it wet. And subjects without pre-diabetic retinopathy changes are less likely to progress So these cases do not require a simultaneous anti-VEGF injections. This very paper you also had quoted. So, and in cases where there is a concurrent central involving diabetic macular edema or non-center involving diabetic macular edema, which are preoperatively, if they are present, they are the high-risk cases for center involving in the post-operative period after cataract surgery. So you need to treat them before going for cataract surgery rather than going for a simultaneous anti-VEGF injections. So my take on diabetic macular edema is one need to have a progression of diabetic retinopathy in mind while performing the cataract surgery. A high-class cataract surgery would not lead to worsening of diabetic macular retinopathy. You need to understand that. No diabetic retinopathy or stable treated diabetic retinopathy they are likely to remain stable after cataract surgery. So no need for intervention or simultaneous intravitreal injections. And intravitreal injections will not be useful in ischemic maculopathy, I already told you. And macular edema tend to worsen after cataract surgery only if it is active. So make it dry before you think of simultaneous injections. Simultaneous anti-VEGF injections therefore warranted only in limited cases. And if macula is dry, it is not indicated. And immediate post-operative assessment is just sufficient for us to decide whether they require anti-VEGF injections or not. And if it is wet, you treat immediate post-operative without wasting any time. Why to go for simultaneous anti-VEGF injections, which may unnecessarily be given if you are not assessing at proper time. So very limited and narrow spectrum of indications for simultaneous anti-VEGF injections along with cataract surgery. We should not go into that era. So more ideal and preferred care is to assess the type of macular edema and treat accordingly either before or early postoperative period rather than simultaneously. I hope you agree with me, Dhanasri, as a VR surgeon. Thank you. This is the last slide I have.
Thank you very much, Dr. Ajit Babu. You can stop sharing. Dhanasri, you would like to say something?
Yeah, sure. So I fully agree with you, sir, Dr. Machi, that you can probably stabilize the patient, whatever before and after.
Yeah.
But here we are debating about a patient who is in need of anti-VEGF. We are not talking about stable maculopathy or patient who has a non-center involving DME or who can be treated with laser. We are talking about a patient who has DME and who has cataract. And what would we like to do with them, whether we treat the same sitting or different sitting? So my
message is to the cataract surgeons, not to you. I know that. That's why I'm very clearly told it is for the cataract surgeons. Okay. So we should not give a message that simultaneous will help them.
Sir, the cataract surgeon can take help of the VR surgeon. We are always there ready to help them. I'm talking about the patient convenience. So it's really convenient for the patient if it is done in the same sitting. Now, especially with this COVID era, you don't want the patient to come again and again to the hospital once for surgery and then again for another injection. So it's quite a hassle. I think better we can finish it both in same sitting. Thank you.
Yamuna, please take on.
Yeah. Excellent presentations from both, and the fact that they were so convinced about their topics, everyone finished well within time. And, points very well taken on both sides. Dhanasri gave us an example where cataract was, yes, I admit, a little more significant than
that was just for illustration. Yeah.
But yes,
you can take another patient with less cataract. It's just
you said blind also. You are blind. Okay.
I wanted to impress upon the necessity for cataract surgery.
I know.
So you can argue that this patient doesn't need cataract surgery. So I wanted to show a photo which actually there is no argument. Cataract surgery is required.
We are all pushovers.
Yes.
Okay.
So definitely when the cataract is dense enough that you get a clue that there is macular edema, but you cannot do much beyond maybe a CT which tells you there is significant macular edema. Definitely it would be a good situation, more practical to treat both. But looking at that is Dhanasri's side of the argument, fully that is well taken and definitely a situation where you would like to do it. But look at a patient who has cataract, not so much, maybe needs macular edema treatment or not. I think most of us would agree that we would like to stabilize the macula before we proceed. So both of them have their courses. And if you have a patient who is on treatment for macular edema, develops cataract along the way, definitely I would think it's more practical to both at the same time. But if it's the first time you see the patient, you can assess the macula well enough, then definitely I would go with treating the macular edema first and then. So I think both talks made their point very clear that there are specific situations where you would like to treat separately and where you would like to treat together. So I think the messages come out very clear from this debate. Thank you both.
Thank you very much. Nitin, Mahesh has joined also. Nitin, please go ahead.
Yeah, the next topic will be on this. We are starting the surgical part of it. Now will be on 3D heads-up vitrectomy. Has it changed your retinal practice? Speaking for will be first Dr. Naresh Babu.
First, we have to start slideshow.
Yeah, we can see the slide.
Yeah, but the problem is I'm not able to go for the full screen, sir. Some problem.
Lower.
Yeah, no. Yeah, now I can.
Yeah, it's okay. Good.
Okay. So thank you, sir. Thank you for giving me this opportunity. I don't have any financial disclosure to be made, actually. And again, I would like to have a disclaimer. I'll not be showing any videos operated with 3D to show off that it's a greater system. Okay, straight away we'll go. This is a very famous dialogue, the message given to us by Mahatma Gandhi. First, whenever a new idea comes, first they ignore you, then they will laugh at you, and then they fight you, and you win. So I think my fellow debater, Dr. Girish Rao, is in the third phase. Now he's going to fight with me, rather debate with me. And at the end, actually, then he will learn with us and he'll win, actually, and you win. So this is the first slide to make. So when you take the life of an ophthalmologist, you become MBBS at 23, maybe if everything is fine, MS at 27 years, fellowship at 30 years, and then you start doing high volumes in your 30s. And what happens in the 40s? With your poor positioning while operating with the microscope, the analog microscope to underline, and your indirect ophthalmoscope, you'll be having back pain, neck pain. And what happens is you feel like retiring at the age of 40, or you will become less productive. So this is what, when you're operating, see, you can see how you sit your is in the heads down position, and you will have to, follow the dictate made by the microscope, and you are not at your liberty to position yourself. So this is the problem with analog microscope. Almost 60% will have musculoskeletal disorder, which is attributed to the loss of productivity. So this can be overcome. So when you have a DAVS, you have got a better ergonomics. You sit at your own comfort. Whenever you want, you just relax, stay back. And the most important point of this particular system is ergonomics. So you don't have any fatigue at the end of the day. So we keep talking to save the doctors from violence. So please procure this machine to save the doctors against fatigue also. So it will increase your, productivity. And second thing is, why you want to have so many separate missions? You can integrate everything in a single machine. So when you have a DAVS system with anterior or posterior system, you can find all the parameters on the screen. Actually, you don't need to every time look into the screen of your, the vitrectomy system to see what is my IOP, what is my illumination, what is my flow rate. Everything will be displayed on the screen. So when you integrate, it's very easy to operate. So this is another biggest advantage. And the most important thing is, see, it is integrated to the cloud in the newer operating system, where you can operate in the operating room, and you can record and see in a remote system with the help of this clouding system. Another biggest advantage of this, the DAVS is I usually operate at 25%. When you're operating with analog system, you'll have to use your light pipe at close to 100%. It is like making your retina a tandoor, actually. So if you touch your arm with your the light pipe, you can feel it will burn you after some time. The same thing will be happening to your retina. So when I am operating, I use only 25 to 30%, almost cutting off nearly 50 to 70% of the light, and thereby the heat emanated by that, and also the phototoxicity. So the phototoxicity induced by your analog, because you are using a higher illumination, is brought down by this system, and thereby getting a better outcome. And this is a better teaching tool. You will be saying like you can teach with the analog connected to the what you call screen, wide screen. You can say that, but you know how we have been taught actually the indirect ophthalmoscopy. There will be a side mirror and the indirect ophthalmoscopy. When the surgeon is performing the indirect ophthalmoscopy and retinal detachment, will be prostrating on the ground to see what is there in the side mirror, and he'll say, "Oh, this is the CD." I don't know what I'll be saying. I'll be saying, "Yes, I am seeing the CD." So you and the person who is learning is also having a very bad position, see his legs and the neck, and you will be not concentrating on what you are teaching. So always teach them perfectly and clarity. The purpose of teaching is not to, disseminate your skill or ideas. You really don't know when you know you need them, because to fix your problem, you will have to produce good students actually. So produce them with clarity and a perfect thing, because whatever you are operating, the person also will be seeing with clarity and will be learning better. The biggest funniest thing nowadays is the honey, which comes with expiry date. You cannot have an expiry date for a pure honey, but humans also come with the expiry date. What happens when you have cataract? You are going to
Naresh, you'll have to wind up.
The last slide, sir. You will have to operate. If you have a vision of 6/24, still you can operate. Without getting operated on your cataract, you can still operate on the patient's eye. So finally, I'll say that this is how we were doing actually when we were going to London in 1960s. There was a bus which was taking 130 days. Even if I'm forced to go to London by bus, I'll be taking a Scania, but not the older bus. And finally, I'll say the change is the only constant thing. You will have to keep changing. And again, coming back to the same quote, first they ignore you, then they laugh at you, then they learn from you, and then you win. That was told by Mahatma Gandhi. This was told by Jivatma Naresh. And thank you for the opportunity.
Thank you, Dr. Naresh. Dr. Girish Rao will defend this topic.
Is my slide visible now?
Yes.
Yes, Girish.
So thanks, Dr. PB, for the invite. I'll be talking on 3D HD. I'm not able to.
भैया कह रहे थे वो 2,500 रुपए दे दिए थे उसने उसकी पेंटिंग के एडवांस.
Tap on the tab bar. Yeah.
It's come.
So I have no financial interest in this presentation.
वाला भेजना था ना.
Can people mute their?
नहीं दिए थे या तो उसने बंदे ने आपको भैया.
Can everybody mute their mics, please?
आप भैया से बात कर लो फटाक से. भैया कह रहे हैं कल तो मम्मी से बात हुई थी, मम्मी ने कहा हाँ अच्छा हुआ तुमने मेरे को रिमाइंड कर दिया.
Can everybody mute their
Can
mics?
you ensure mute others, please?
Dr. Naresh said that the only thing constant in life is change. But do you really need change just for the sake of change? Now, we have seen that vitreoretinal surgery over the years have benefited by technological advance, be it in the fields of the microscopes or the viewing system. We have migrated from the irrigating lenses to the wide angle viewing system, and also the advances in the vitrectomy itself, from the 600 cuts to almost 20,000 cut systems. And all these advances have not only benefited the surgeon, but have also benefited the patient. They have made surgeries faster, safer, with better surgical outcomes. So these are the technologies which we have embraced very swiftly and very willingly. Now comes this latest kid in the block, the 3D HD. We have this RTO system from the Zeiss and the Ingenuity from Alcon. Now, for the sake of my argument, I shall be quoting most of the texts from these two publications, one from the Wills Eye and the other our own experience that we had during the demonstration of this system a couple of years back. Now, the claimed benefits of the 3D HD system is definitely the improved ergonomics, reduced illumination, enhanced stereopsis, magnification, and also the image manipulation. Now, better ergonomics. Definitely the heads-up system does probably give a theoretical advantage of having a better ergonomics because we are eliminating the use of the microscope lenses. It definitely depends on the screen placement. But what it actually happens is while your back straightens, your head turns. And now you're ending up operating with a head turn for a long period of time. And also the orientation of your hands as compared to with the head is slightly dissociated. So whether we are replacing our back pain with a neck pain is for time to tell. Reduced illumination. Now, standard illumination used during the vitrectomy has not believed to cause any phototoxicity, and we have been doing this for years together. I do concede that reduced illumination could be beneficial, but the standard illumination was definitely not toxic to the retina, especially if you use it not at 90 or 100% as Dr. Babu was saying. Even if you do it at 60, 70%, you will still get a reasonable illumination. What the heads-up system has, the Bill's eye study showed, is that the macular surgical time was much longer with the heads-up system as compared to the conventional. So longer duration with low illumination, whether it negates the actual advantage of low illumination. Look at the enhanced stereopsis and the depth of field. Now, this heads-up system eliminates the surgeon's accommodation. So what we are relying on the HDR cameras, which has limits to its exposure modulation and the depth of focus. Especially in myopes, this could be less forgiving and compromise the view itself. Magnification is great. Everyone wants it, especially to see everything large. But what happens is when you're working in high magnification, you need to refocus very frequently. Even slight change in the depth of focus compromises the view and actually ends up in delaying or lengthening the surgeries. And obviously, if you have fine tremors, this gets highlighted much more under higher magnification. We have a theoretical advantage of all the filters, whether it's blue, green, yellow, with this digital image manipulation. But what the Will's eye study showed is that between the two groups, there was no difference in the use of dyes, either the IVTA to stain the vitreous or the need of dye itself for the ILM staining. So it does show that this is still a work in progress. So we obviously know that there are potential disadvantages. A bulky system, especially in a small operation theater, could compromise and would actually be a hindrance to the anesthetist. We all have the learning curve, which I'm sure the good surgeons would overcome in a period of time. But what probably is the biggest hindrance is the latency, especially more pronounced during anterior segment surgeries, and the cost factor, anywhere between 1 crore to 3.5 crores. So change for the sake of change, one needs to really look at what is the charge that we are going to incur for this change. So HD is definitely a technology tool for the future. It's a work in progress, probably a wearable device with better or no latency at all, better filters, data integration so that we can use AI for interoperative decision making, and obviously cost rationalization could help in this scenario. Thank you.
Thank you, Dr. Girish. I'll hand over to Dr. Mahesh for his comments.
Thank you, Dr. Before that, Naresh would like to have some comments.
Sir, actually, Dr. Girish Rao was talking about the tremor. Tremor is not the problem of the microscope or the operating system. It is the problem of the surgeon. Okay, so if it is getting exaggerated, I think that is not the problem of the machine, number one. And number two, in the last slide, he has put it very nicely. He's saying he's accepting, except for a few problems. So probably all those problems which will be sorted out, which has been already sorted out, probably from next OR onwards, he'll be operating on a 3D system. All the best, sir. Thank you.
Yeah, thank you, Pramod, and thank you, Nitin. And both of them have put their arguments in totally different ways. Girish Rao was the professorial controlled one, and Dr. Naresh went for the belt. And the crazy part is both of them are using the machine, and I am the only guy who's not using this machine. So I'm supposed to be judging this. Okay. So, and Dr. Naresh was saying that he was comparing himself to Gandhiji and starting an ashram. Gandhiji was for austerity. And you're like, and he was going around in one towel. And then you're saying that 0.8 crores and 3.5 crores, you have to buy an equipment, and saying that like you're saying you're like, obviously you cannot compare yourself to Gandhiji, and I can sense the type of ashram you're going to start, I guess. Yes, both have their pluses and minuses. Yes, it's not as though like you cannot live with this machine. You have like you can do your surgeries quite well with your machines. The problem with the microscope is you have to sit properly, and like all the images which are shown, Dr. Dhanashree was not sitting properly with her eyes straight, and the eyepieces. Like if you're able to have it at the eye level, it's fine. Yes, that definitely has advantages. You are able to teach your fellows much better, and they see much better. But the issue is you need a larger theater because it has to be kept at a particular distance from where you're sitting, and it may not be an uninterrupted view to everyone. So like the microscope arm does come in the view of your assistant also. So you need a sufficiently large theater that like it's an uninterrupted view for everyone. My problem with this equipment is it's particularly expensive, number one. Number two is they are not able to eliminate the microscope. So you still need a microscope, but instead of the oculars, you put a camera there and you're seeing in front and operating. So I would shift over if at all, but then like if the expense comes down, not at the present cost, and it's not equipment which you definitely have to do the surgery with.
Thanks.
Yeah, you can go ahead, please.
Thanks, Dr. Mahesh, for a very frank opinion about the two talks. The next debate will be on ILM peeling during vitrectomy for primary rhegmatogenous retinal detachment. Would you peel in all cases? For this would be Dr. Saravanan. You can start your slide, Dr. Saravanan.
Thank you, Nitin, sir. So I'm debating for peeling in all cases, because the reason being that now most of us have shifted, most of our RD practice is more towards vitrectomy rather than buccal, which was the case in some 10 years back. So then we are dealing with complications of vitrectomy like PVR and epiretinal membrane, which are quite common. There have been multiple articles highlighting the risk of developing epiretinal membrane following vitrectomy. The mechanism is a little bit different from the routine idiopathic ERM. Here we have the RP cells which are migrating from the subretinal surface through the breaks onto the macular surface and proliferating as epiretinal membranes apart from the hyalocytes, the role of retinal hyalocytes and retinal glea. And ILM acts as scaffold for this growth. And it has been postulated that removing the ILM will remove all these ERM originator cells from the macular surface, leading to better outcomes. This is an article showing the occurrence of epiretinal membrane out of 141 eyes. They showed that 12% developed ERM, of which 1/3 needed to go for epiretinal membrane removal as a second surgery. So that's very significant actually. And this one more study showing the 1-year follow-up in 135 patients where they had that there was a risk of developing ERM only in 0% in ILM and 21% in without ILM peeling. And there's one more study showing the risk of ERM development, and they show that it was removing the ILM during the primary surgery was able to significantly reduce the development of epiretinal membrane in the post-operative period. But even though the vision was more or less comparable between the two groups. Again, this one more study showing the impact of ILM peeling on redetachment rates also. They showed that it was significantly reduced the risk of redetachment apart from the ERM itself, and repeat vitrectomy rate also was very, very less in these eyes. And this is on meta-analysis which showed that all the published articles they tried to wholesomely analyze, and they showed that there is a significant risk of preventing ERM formation and also recurrence of RD in postoperative, but vision was more or less same between the groups. So how does it help is that peeling ILM relieves all the tractional process. If there's a macular hole at percentage, it may help to close it. And also, not only that, on Korean article with the short series, they showed that when they were operating for redetachments, by doing ILM peeling, they were able to prevent doing relaxing retinectomies in the periphery. Sometimes you may ask why small ILM peel in the posterior will relieve the peripheral retina. Here you can see that a small tug in the right direction can produce the desired effect in the critical areas. This is one article by Dr. Prashant sir, who showed that ILM peeling, he compared 3 groups, no peel, ILM peel only in the macula, and ILM peel including the macula in the peripapillary zone also. we showed that significant risk of significant reduction in risk of developing both ERM and re-RD was seen in the peripap macula with ILM peel, which was slightly less in the ILM peel and which was the least in the no ILM peel. So ILM peel was better than no ILM, and ILM peel with peripapillary ILM peel was better than the central group also. So other counterpoints will be that doing ILM peeling is going to produce a lot of subtle damage. We have been doing macula hole surgeries for so many years now, and all these changes are seen in almost every patient. After 3 months, we do OCT and autofluorescence, you'll be seeing all these dimple signs, the dissociated outer nerve fiber layer dropouts. All these things are seen, and we are never bothered about the visual outcome because it's very negligible. All these changes produce very, very little visual outcome, and when you're not bothered about operating in 6/6 size, then you're not really bothered about operating in a macula of RT. So another will be the risk of, difficulty in doing ILM peel, and putting a PFC is going to help very much. So stripping leads to success. Unless you strip, you cannot see God. So I hope everybody starts stripping. Thank you.
Thank you, Dr. Sarunan. Dr. N.S. Muralidhar will be speaking for no ILM peeling in primary rheumatous retinal detachment. Murli.
Yes.
Wonder what he is going to strip.
I'm a no stripping man. Sorry to disappoint you. Can you see my slides and am I audible?
Yes, yes.
Yeah, you are.
Okay, thanks to Pramod for giving me this opportunity, and Saravanan did a very good talk. And I'm going to talk against ILM peel in RD surgery. We all know that ILM peeling started as a part of macular hole surgery and became a standard step in a macular hole surgery. But over the past decade, we have seen that it has become something that is done in almost all the vitrectomies, and probably I feel it has become a fad. I feel you have to prove yourself by peeling the ILM that you have your vitreoretinal surgeon. It has reached that stage. So people are peeling the ILM left and right and saying that once I go into the eye, I don't come out without the ILM. This is the statement. But what's the evidence? I think Saravanan did present this evidence. There are many studies in the literature. He also quoted some. What we have to remember is most of them are retrospective and there are very few prospective studies. And this again is the study which we are going to talk about a little bit more detail. This is a meta-analysis which Saravanan alluded to. They pooled 9 studies. Remember, only one of them was a randomized control trial. Rest of them are all retrospective. So they essentially said the same thing. Then the peel group and the non-peel group, they looked at the ERM formation and the visual outcome. There was no difference in the success rate, no difference in the vision recovery. The only difference was that ERM formation was prevented by ILM peel. And this overall in the vision, again, there was a little difference because in 4 studies in this and a meta-analysis, vision was better in the peeling group. And in the 4 other studies, vision was worse in the peeling group. So the final word about the vision being better in the ILM peeling group is yet to be said. So the one thing we have to understand and notice in all these studies is that in spite of more ERMs in the non-peel group, the visual outcome was the same. What does it mean? It means most of the ERMs in these patients were not visually significant. We all know that ERMs can exist without causing vision problems. We see so many idiopathic ERMs where the vision is 6/9 and we don't touch them. So similar is the case in post-RD surgery ERMs too. We don't go around removing all of them just because they exist. So conclusion of the meta-analysis, it reduces the incidence, but no vision, no difference in the visual outcome. So is it enough to justify ILM peel in all the cases? Let us look at this study. Saravanan did not want to quote this study. This was done as a prospective randomized trial, 30 eyes in each group, vitrectomy with silicone oils with 6 months of follow-up. They studied the OCTA and ERG, multifocal ERG, in addition to regular vision. And what did they find? They find that the vision was worse off in the peel group, of course, and the vessel density in the superficial capillary plexus was worse off in the peeled group compared to the non-peel group. Of course, ERM formation was more in the non-peel group. And finally, the P1 amplitude of multifocal ERG was worse off in the peel group. So here there is evidence to say that there is a definite effect of, deleterious effect of the peeling on the retinal structure and the function. So in conclusion, ILM peel during RD surgery can reduce ER formation, agreed, but none of these can affect the vision to a great extent, and peeling an ILM is technically challenging. I know PFCL can be used, but it's an additional step. You're going to introduce PFCL. Normally, I don't like to use PFCL in a simple rhegmatogenous RD. I do not use PFCL, in all the cases. So it actually adds about 15 to 20 minutes to your time. And there is a potential for iatrogenic damage. Especially, I can imagine a novice surgeon who is not experienced trying to peel ILM. You can easily cause a retinal break close to macula, and end up with much more problem than you started off with. So we need larger studies to identify. I'm sure there are some mice which benefit from ILM peel. Would you like to peel ILM in a macula on RD? That's what I would like to ask Saravanan. Would he peel in a macula on RD? So I feel ILM peel is definitely not on in all cases. Select them judiciously. And thank you for your attention. Thank you.
Thank you, Dr. Muralidhar. Thanks to both the speakers for being within time. Dr. Saravanan, a quick comment from you before Dr. Mahesh takes over.
As article in the IJO, Indian Journal of Ophthalmology article, was a prospective study where he showed that not only the ERM, but they were able to reduce the risk of recurrent retinal detachment also in the ILM group, in the group where they peeled the ILM both in the macula as well as the peripapillary zone. So that is one prospective study which showed success. And all these negative effects of ILM peel are very subtle and rarely affect vision, which I showed because we have been doing this peeling for all macula holes for so long. And even though this was one of the reasons why temporal flap was advocated, we hardly see as a visual deterioration in these patients following ILM peel in macula surgeries. Those are all like 6.6 and 6.6 parts or 6.9 parts. When you're not really worried about addressing the ILM in such good vision, especially in macula of RDs, what's the big what do you say, trouble or reservation in such cases? That's what I wanted to say.
Thanks. Dr. Mahesh, your comments?
Dr. Saravanan, you have not still answered Dr. Murli's question about whether you'll peel in macula on. Yeah.
Probably no.
Yeah. So Dr. Muralidhar managed to put across his arguments very effectively without showing provocative photographs of actresses or any other images. So yes, but
the very fact that he needed to use them means his arguments are weak.
Yeah, but also he very effectively, very cleverly didn't talk too much about recurrence of retinal detachment. So that was one of the positive points for peeling the ILM. So even the meta-analysis shows that if you peel the ILM, the recurrent RD rate seems to come down. That's one of the reasons why some of us do peel the ILM nowadays. Yes, macula on RD, yes, we would probably not peel the ILM for the risk of decreasing a subsequent ERM formation. But ILM peeling definitely does have a role in identifying a subtle epiretinal membrane, which is causing, or rather the very early PVR, which is not very obvious. So you can peel I stain the ILM and start peeling it. That kind of gives us a handle to the subtle PVR, which we can peel also. That seems to be a positive factor for peeling the ILM. Yes, we may not be peeling the ILM in every patient of RD, but with a subtle, probably grade B PVR, peeling the ILM seems to help in decreasing the rate of recurrences, is what I would think.
Thanks, Dr. Mahesh. We'll go to the last topic for today's debate, that is silicone oil injection in endophthalmitis with attached retina. Dr. Manish Nagpal will be speaking for this, and Dr. Avinash Patange will be speaking against this. Dr. Manish?
Thank you, Nitin. Thank you, Pramod, for the invitation. Can you see my screen and am I audible?
Yes.
Okay. So I'll be speaking about the role of silicone oil in endophthalmitis. I know it's not a standard of care, but over the last 15 years, I've been using it in almost 60 to 70% of cases of endophthalmitis. And I'd just like to show you the variety of cases that I feel it has a good potential and role. Now, endophthalmitis comes in all types. It could be low grade to very small hypopyon, almost clear media with mild fuzziness, to something which goes to a very steamy cornea with a lot of hypopyon, a lot of exudates inside. So one has to actually see a variety of cases and then decide where this probably is feasible. So the traditional approach for vitrectomy But look at the EVS, there is also a mention of additional procedures. You do a core vitrectomy, and after in the follow-up, you may be dealing with a lot of situations such as a recurrence of infection, secondary breaks, which might have led to detachment, PVR, or a gross hypotony. And then there is management for those kind of situations also. So that's an aspect which we don't usually look at the beginning when we are dealing with just doing a vitrectomy for endophthalmitis. So silicone oil in endophthalmitis, according to us, what we feel is it allows a good cleanup in cases with extensive exudates. You can take liberty to do a very good peripheral cleanup, tamponades the retinal defects in case you have an iatrotic break or a missed break, which was there because of the inflammation. And anyways, breaks are more likely in these inflamed eyes. Contains any inferior detachment till the eye is quiet so that you can tackle it later. Otherwise, it goes into a very early PVR. And with inflammation, it's difficult to tackle it very fast and prevents severe hypotony in the post-operative period. So these are extensive exudate in the periphery type of cases, which could, where if you just leave them after doing a core vitrectomy, they lead to a lot of other problems. And of course, literature does talk about the inhibitory effect of microbial growth and reduces the recurrence rates. And there's a lot of data on that as well, which is there. So we had published our early experience in 2000, where we compared a large group of patients which we had done core vitrectomy versus core vitrectomy with silicone oil. I'll not go into details for paucity of time, but essentially we looked at, compared a lot of things, including visual acuity, recurrent surgeries, any requirement of additional procedures, control of infection. So this was the kind of numbers that we had, 63 in core and 55 with oil inside. We also had a post-traumatic subgroup, which of course is a different aspect, and it was a part of this study, but we had put subgroups to them while discussing it. So these are examples of cases which had sort of a low grade enough. If you see, there are opacities which you have intravitreals earlier, maybe have resolved to some extent, then there's recurrence, so you go in. A lot of P-NS type of infections you go in. So these, of course, we resort to typically a core vitrectomy, while those which are peripherally spread out fungal or have exudates in the periphery, we like to do a full-fledged vitrectomy where we would also like to peel and remove everything. And this liberty you can take if you know that you're probably going to put oil inside. These kind of cases where you have this whole peripheral area which is totally blocked with exudates. And if you leave all this just by clearing the central part, all this is going to bring in possible recurrence in the end. Now, this is a case of a steamy cornea with hypopion also there, and of course, posteriorly there's exudates. So first of all, we clean up everything anteriorly. We remove these organized membranes which form with the hypopion, and then of course go back inside. And you can see that this is the kind of case which I showed you earlier with low grade one. So this is exactly what we take as a gross distinction, where we decide that, okay, this is a case where I will like to put oil and I will go as much of a cleanup as I can, take the liberty to remove hyaloid, remove as much, and then put oil and follow these cases up rather than not put oil in these cases, because otherwise here my visibility is not great, and I'm going to leave behind a lot of stuff in case I'm not confident of putting oil inside and make it breaks, and or there may be a detachment and I'm not happy, or there may be a hypotony or a recurrence, and the compartmentalization.
You'll have to wind up first.
Yeah. So these are, I mean, I basically wanted to show you that these are the different varieties of cases. And so the 60 to 70% of cases of these sorts is where I would typically put oil inside, while others I would do core vitrectomy.
Thank you, Dr. Manish. Dr. Avinash will be speaking against using oil in endophthalmitis patients.
Yeah, thank you, sir, for giving me an opportunity here. So if you look at the slide, the standard of care in the management of endophthalmitis happens to be antibiotics, intravitreal, to some extent the systemic, past vitrectomy, biopsy, and steroids. So nowhere in this you find silicone oil as a standard of care, and why are we debating about it, especially in an attached retina? So I would like to extend the debate on these four subheadings. The first of which happens to be the influence by the type of the organisms and antibiotic susceptibility. So when you look at the type of infection causing endophthalmitis, we extensively studied and published 3 reports on what would be the common source of organisms we found in our subset of patients. And fortunately, most of these patients happens to be gram-positive organisms. And amongst the gram-positive organisms, coagulase negative staph happens to be the most commonest organism causing endophthalmitis, whether it's going to be post-operative or it's going to be post-traumatic. So we all know that outcomes of endophthalmitis caused by coagulase negative staph is one of the best outcomes we can ever get. So majority of the organisms, gram-positive, among them coagulase negative staph, they have very good outcomes. Why oil? So, and certainly the debate can extend to a small subset of patients where we have multi-drug resistance and them among being the pseudomonas, but they form only 1.5% of our patients what we have reported earlier. So having understood the organisms, most of the organisms, if you look into the gram-positive, over 98% of them are sensitive to vancomycin. And there, if we have an antibiotic to which the organisms are primarily sensitive, why inject silicone oil? With that, I will move on to the second objective. We have to understand the pharmacokinetics of the antimicrobials in silicone oil filled eye. To be frank, we have even published a paper of how silicone oil possesses antimicrobial properties in vivo. And having said that, it doesn't mean that this could be used as a primary or the first line treatment in the antimicrobial cover of endophthalmitis. So we also have to understand the pharmacokinetics. We published this paper, but to the extent that we have no paper which says the pharmacokinetics of antibiotics in a silicone oil filled eye. We have no publications on that. And what happens is when we inject the antibiotics just after the fluid exchange happens, and then we inject the silicone oil, the antibiotics gets trapped between the oil and the fluid interface inferiorly. So there is a possibility that the organisms which get sequestered anteriorly tend to remain there, and these antibiotics would not find a place. Now, in case of persistence or even recurrence, like what Manish had mentioned, if an oil is already been filled, what is the concentration we are going to use? We know that it is going to be 1/4 or half concentration before injecting the oil. But within the oil, we are not sure whether it's going to be half, a quarter, or it's a full dose, and how long does it take to act and eliminate from inside the eye. With that, my third question is, does silicone oil prevent retinal detachment? So we know that the 2 most important causes of retinal detachment in a patient with endophthalmitis is extensive amount of vitrectomy, especially the ones where we are not able to see what's happening in the periphery, and the inflammatory milieu being so critical to create those peripheral breaks, which we may not be able to see on routine surgical procedure manipulations. And also understanding the fact that endophthalmitis are mainly caused in cases where the organisms have been highly virulent, like the gram-negative ones, where the higher chance of retinal detachment. So, but even when there is a condition of persistent endophthalmitis where there is the chance of oil being injected into the eye, so there is another problem what we face is when the premacular bursa is not being able to remove, or when we have an ERM formation, there is a double layer ERM which forms whenever there is an infection in the eye with an oil. The top one is very similar to the perisilicon membrane, and the lower ones is very densely adherent to the macula, which can create sometimes can create a retinal break when you try to peel the membrane. And sometimes when we have to either sacrifice the lens or intraocular lens or a clear lens, or so we might create in one chamber, and we have problems of oil migrating into the anterior chamber, and it has its own set of problems. So how about the outcomes of silicone oil filled eye? And one of the important questions is, can it reduce the additional procedures? We know that about additional procedures are more common in patients who had virulent organisms, what is reported in EVS. The other published which has happened does not indicate that
Avinash, you'll have to wind up fast.
with silicone oil, the additional procedures can be reduced. So repeat procedures are associated with decreased outcome, and the visual outcome primarily depends on the type of the organism and not on the usage of silicone oil. Thank you very much.
Thank you, Dr. Avinash. Thank you, Dr. Manish. A quick word from Manish before Dr. Mahesh takes over. We're running short of time. We're just about 2-3 minutes left, I think.
Thank you, Avinash. Excellent, and I think your everything is backed by data, and I don't argue at all with the fact that not standard of care. It doesn't prevent detachment, like you said, but it contains, as I mentioned, it allows you time because there is a segment of patients who will come back with some sort of inferior fluid or detachment, which will be hidden in case you haven't put compartmentalized with oil. It takes time for you to diagnose, and by that time it's PVR, and I'm sure all of us have experienced those cases, or sometimes they go into thysis. So oil gives you a lot of leeway in these bad cases, which have a steamy cornea with membranes in AC, exits behind. But of course, for the classic end of, I would agree totally that we do core, we still do core. We still do a significant variety, which is oil, and we are quite happy using it.
Dr. Mahesh?
Yeah, I think it was a very balanced debate, and they both kind of agreed with each other about where you would use it. So a simple end of where you're pretty much able to see the fundus or just about the red glow is there. There's no need to use oil in an attached retina. But in the advanced endophthalmitis, where the vitreous is so thick and you know that you may be creating a break in the periphery, or it's a particularly virulent organism, is where you would probably use the oil. The argument is like Avinash himself is an co-author of one of the recent articles about silicon oil being like antimicrobial. But then he himself is speaking against it. So that was a kind of issue is here. So I would probably think, yes, silicon oil has a role. You would probably, some of us who were totally against using silicon oil probably will be using it in very difficult patients or patients who have an extreme kind of endophthalmitis. But the simple endophthalmitis will still go ahead without doing it, without using oil.
Thank you.
Thank you, Mahesh. And I think maybe just quick recap. Thanks everybody for lively debate. Quick recap, I think Nitin will do just in 30 seconds, and I think yes, we'll close it. Let me thank everybody in advance. Thanks for being a part of things.
Overshot by 1 minute. Just a quick recap. The first 3 topics for medical retina. Dr. Mona has a good future in diplomatic as a diplomat in a career. So to be fair, the topics are like that. I think she agreed that there is a role of OCTA, there is a role of FFA ICGs in given cases. Monotherapy, as of now, probably no, but in future, we may be looking at if there is some newer drugs, newer medications. Cataract DME, again, there are situations where you would give it together, you would prefer to give it together, but there are situations where you would look at it giving separately also in that time. Dr. Mahesh covered up the other 3 topics where he spoke up about the 3D heads-up vitrectomy. He is not in favor of it right now, primarily from the cost factor, even though it has a lot of other advantages. Regarding ILM peeling for and against, there are situations where you do, situations you do. He tilted towards doing more of ILM peeling, to basically from avoiding recurrent retinal detachments. And silicone oil injections in endophthalmitis patients has its role. In simple vitrectomies, you won't be doing oil injections. For more complex, as Dr. Manish has highlighted, cases where you're worried about the retinal status, you would consider doing it, injecting silicone oil. Dr. Pramod, last word.
Thank you, Nitin, for covering up, summing up everything. And thanks all the panelists, all the debaters, rather, I would say, and Mahesh and Muna for
nice to see all of you.
Thank you so much.
Thank you, everyone.
Yeah. Thank you. Thank you. Stay safe.
Wonderful session. Thank you so much.
Really great session.
Yes.